we put this lecture in a YouTube channel, Vince, and I think it's Adrian Safa who's here. He coordinates and he's archived a few hundred lectures already, and they do a beautiful job. They edited them and stuff like that. So we thank you for allowing us to do that.
Yeah, no problem. My pleasure.
And as Kai said, in any given morning, we have between 10 to 13 countries represented, people from a lot of corners of the world and the United States, in addition to our teams as well.
Yeah, that's awesome that you guys can reach out like that.
We try. Like I see Isabel right here. She's from Madrid and she's joining us all the way from Spain. So, you know, I recognize at least one person.
So I think it's 7:01. I don't know, Dr. Q, Dr. Chan, if you think it's okay to start.
Yeah, I think we can start. It looks like a lot of people. We have 33 participants already, so I think we should be good to go. Okay, so I'll introduce you, Vince. So it's my pleasure, everybody, to introduce Vince DiNapoli, who's coming to us from Cincinnati from the Mayfield Clinic. He's obviously, if you see his CV that's attached, most people should be able to see it. But he's quite accomplished. He did his med school and PhD at West Virginia University. And following that, he went to the University of Cincinnati, where he did his residency. He then did a fellowship in skull-base neuro-oncology with Dr. DiMonte at MD Anderson. He's had a lot of interactions with us indirectly. One of my co-residents, Sean Raza, was one of his fellowship directors at MD Anderson. He comes highly regarded. So welcome, Vince.
Yeah, thank you, Kai. It's a pleasure to be with you guys, and certainly enjoyed my time spending time with you guys last couple of weeks ago. I'm gonna try to share my screen here.
And Wendy, you want to say a few words, since you're also one of the hosts. Thank you, Wendy.
Yeah, no, I'd be happy to. Yeah, no, just wanted to highlight Vince's really impressive development of a brain tumor program where he's at. And we talked about the complex system there in Cincinnati, and he's really developed a really vibrant program with clinical trials, nurse navigation, active multidisciplinary work. So I'm really excited to hear a little bit more about what he's been doing.
Thanks, Wendy. Can you guys see my screen there?
Yes.
Sounds good. All right, well, yeah, thanks, guys. Yeah, today I was just going to talk about kind of what I've been up to over the past roughly 10 years since graduating fellowship here in Cincinnati, kind of go through some case presentations and how that's kind of led our development of our brain tumor center here at Mayfield Clinic in Cincinnati. So I don't have any major disclosures. I am a principal investigator and a consultant for GT Medical Technology. So just to kind of give a little bit of a background for what's been going on in Cincinnati. So Dr. Mayfield established our practice basically back in the 1940s. Him and one of his partners, his partner actually established a program at the University Hospital, and they both established residency programs. And then over the course of years, the university program and his program actually merged into one program. So that's how the Mayfield Clinic existed for almost 75 years. And that's how it was when I was training here in Cincinnati with Mayfield. They administrated and ran the Department of Neurosurgery and the residency program at the University of Cincinnati. It was a really vibrant and active program. And then after I finished my fellowship with Dr. DiMonte in Houston, I decided to come back and join them as a faculty member. Currently, as it stands, this is our current cohort of neurosurgeons and PM&R physicians. I realized as I looked at this picture last night, we have a little bit of a diversity problem, but we're working on it. So as I said, I joined Mayfield in 2015 after finishing my fellowship. I initially joined as an assistant professor at the University Hospital in an academic track. And then when we split from UC in 2018, I was kind of charged with establishing and building a new brain tumor center and neuroscience center within the Mercy Bon Secours network, which is the largest healthcare system here in Cincinnati. They have 6 total full-scale hospitals. And it's actually a national network. They own, I think, roughly a little bit over 50 hospitals nationwide across the Atlantic seaboard and into the Midwest. So, coming from fellowship and having just gotten board certified, it seemed a little bit of a daunting task, but because we were kind of building this from the ground up. I initially worked with Mercy and the board there, joining their board in 2019 to secure funding of approximately $15 million to invest into neuroscience and establish a regional referral center for the Mercy network. We started by creating a transfer process and made Jewish the hub. So kind of created a hub and spoke model where all patients were transferred into Jewish. And then looking at the hospital itself, we really had to do a lot of education and building into the staff to educate them and get them up to speed with taking care of these complex patients. So we established what we called a Neuro 101 lecture series, where we invited the floor nursing, ICU, OR staff, et cetera, to a group every 6 months where they got a chance to listen to didactic lectures about neuroscience patients, and then also go into the lab. We had some cadavers there where they got to place CVDs and do some spine procedures and kind of learn more about what we do in the OR and outside the OR to take care of these patients. The hospital made a great investment in updating the ORs and buying us all the equipment and instruments that we needed, intraoperative imaging. And also happened to coincide with the opening of a new 200-bed tower with all private rooms and a new ICU. And so it all coalesced and came together in a pretty good way at that time. The only downside was they had only done 2 craniotomies for tumor in the past 2 years at that hospital. So, where do we start? So I think, as I thought about it last night, I think as we grew the program, it really was driven by, patient care and us wanting to provide the best possible care for all the patients that came through the door. So we kind of grew organically as we needed to with each of the patients that we were taking care of. So just for a case presentation, one of our first patients that we took care of it from a brain tumor standpoint was a 46-year-old gentleman who presented to the emergency department with a seizure. He was brought in by squad. When he got his MRI, it demonstrated a T2 hyperintense mass in the left frontal area. This is his initial preoperative scan here. You see the mass there in the kind of posterior middle frontal gyrus, kind of extending down almost to the top of the ventricle. Suspicious for glioma, obviously. So he was taken for maximal safe resection. And this is his initial postoperative scan. So he did, his pathology was consistent with glioblastoma, IDH mutant, MGMT methylated, and he ended up undergoing Stupp protocol initially, which we do the same way everybody else does, and then I think that kind of as we took care of these patients, it drove our development of the program. Glioma patients require really a multidisciplinary approach. We needed to involve multiple subspecialists from multiple different groups here in Cincinnati, as we don't house all these subspecialties. So it forced us to forge collaborations with great people across the city. Dr. Sengupta was one of the best partners that we had. She's a neuro-oncologist down at UC. I think she's now joining Duke's group, or North Carolina's group here this fall. But really a great collaboration with her for neuro-oncology at UC. We also formed a collaboration with OHC, who was a large oncology group. They have neuro-oncology and radiation oncology and neuro-oncologists within that group. So we started to kind of develop a team approach to these patients. That forced us to think about developing our tumor board. So we convened our first tumor board, consisting of all these different subspecialists. And then as we developed that, we went ahead and applied for the JCO gold seal of approval for brain tumor center, and we were able to establish that in 2019. So this same patient, interestingly enough, returned to about roughly 3 years later after his initial resection and having undergone adjuvant therapy. And you can see there at the inferior margin, the deep margin of his tumor resection, he's got a recurrence of enhancement there. He had undergone, upon his initial recurrence, which was before this, he had undergone immunotherapy clinical trial at Ohio State. So he didn't have a whole lot of, options at this point when I saw him again after failing the clinical trial, and he had progressive enhancement there. So again, pushing us to kind of continue to develop things. We were looking for options for these patients, especially our GBM patients who didn't have a lot of hope at that point. And we adopted the use of gamma tau radiation for, in the recurrent setting for GBM for patients who had failed clinical trial. For those of you not familiar, it's a new technology with, it's much like the traditional brachytherapy we've used for years with I-125 seeds. This is a cesium seed that's got a shorter half-life, and it's embedded into a surgical wafer or patty that you place into the surgical bed when you're done removing the tumor. I think the biggest advantage of it, one is the half-life of cesium is much shorter, so the radiation gets delivered in a quicker way, and there's not as much concern for contamination of people around the patient after surgery. The other thing is it's so much quicker to place, so you can place these towels into the surgical cavity within less than 5 minutes and deliver the therapy without having to sit there and glue seeds into the brain for 20, 30 minutes, which can be very tedious. So it makes it very accessible for the patient and also for the surgeon. These are designed to give approximately 60 gray to a depth of about 5 millimeters, and the half day is approximately 10 days. So 95% of the dose will be delivered within 6 weeks. The way that we've used it thus far, and we've expanded since then to using these in brain metastasis patients, especially for solitary metastasis that require surgery. And we are part of the Rhodes trial directed by MD Anderson, the clinical trial, looking at that versus stereotactic radiation. We've also used it in a couple of patients who have had failed treatment for atypical and aggressive meningiomas, using these tiles against the dural margin where the dura can't be resected, like in places such as the superior sagittal sinus and other areas where you can't necessarily cut out the dura. We've placed those tiles up against the dura there, and that seemed to be effective. The workflow for these is a little bit cumbersome. You have to order the tiles ahead of time, so your patient has to wait 2-3 days for surgery. Even if they're an inpatient, that can be sometimes a little bit of a hassle, but they've been pretty good about turning that around. That's kind of our series of patients that we've done thus far. The other thing we looked to advance for our glioma patients was the adoption of 5-ALA. So we found that this kind of has improved our gross total resection for contrast enhancement in glioblastoma. We still use, the way I've used it is, I've approached it is taking out the tumor as I normally would, doing an extra capsular dissection around the tumor, trying to remove all of the contrast enhancing portion as I normally would. And then at the end, once I think I'm done, bringing in the scope and the filter and taking a look around the area and making sure there's nothing there that's coming up positive. And it's anecdotal at this point, but I do feel like it has definitely given us a lot more of like the perfect post-op MRI where you see no enhancement around the margins of the cavity. And then we also have adopted the use of Optune for some of our patients with GBM. And this is the post-op scan for that patient we just discussed, with showing the resection there of that contrast enhancing portion down to the surface of the ventricle, and then the placement of the gamma tile seeds. The other nice thing about the gamma tile is that when you're adjacent to a ventricle and the ventricle is open, the wafer seems to keep the seeds within the cavity, and we haven't seen any migration of the seeds, which was a problem before. We'd have seeds ending up in down in the brainstem or the lumbar cistern as they migrated, which if they're still active could be dangerous. And then this patient actually I was recently seen a couple months ago, 5 years follow-up, and he's still doing pretty well from his resection. There's no progression of his contrast enhancing, there's no nodular enhancement in his cavity. So as we progressed, the second patient I was going to talk about is a 37-year-old who recently presented with a new onset partial complex seizure occurring several times per day. He had no significant past medical history, very healthy young guy. His MRI revealed a very large T2 hyperintense insular brain mass. And he was actually taken for stereotactic biopsy at the outside hospital with his pathology reported below. It was a low-grade oligodendroglioma. And at that time, he was actually recommended for Stu protocol by the outside hospital without any definitive resection. He was actually sought us out for a second opinion regarding his resection. So this is how he presented to us. You can see this large T2 hyperintense mass, mostly within the right insula, and it kind of extended down into the temporal tip around the candelabra of the MCA. So I have enjoyed, I did some time with Fred Lang at MD Anderson. I do enjoy kind of insular low-grade glioma surgery. Has been something I've really enjoyed developing. And so we discussed this with him, and given the low-grade nature of the tumor, we felt that a more definitive resection would be beneficial to him. So the way we do these is I take a or a transsylvian approach. So we do a wide opening of the sylvian fissure, an anatomic dissection of the insula, and we were able to, at least so far, as far as I can tell, achieve a gross total resection of the tumor. So the interesting thing about this, I think, to discuss maybe later would be, do you or do you not put this patient through any more adjuvant treatment at this point, or do we just surveil him? Something so we developed around our low-grade glioma patients has been the use of intraoperative MRI. We don't use it a lot, but in these low-grade glioma patients, I think it has helped a lot with making sure that you get all of that flare signal out of the area. So we would basically take the patient to the OR, take the tumor out. When we think we're done, we go to the MRI scanner. We check the cavity, and if there's anything there that we think is residual, they'll come back to the OR, and we'll remove it before we definitively close the wound. We've also adopted a functional MRI and NDTI for these patients as well. And then we also have been developing an awake craniotomy program. This is one of our first patients, had a low-grade glioma in Broca's area on the left side, obviously right in the speech territory. Her functional MRI confirmed that speech was wrapped around that tumor. So she was our first awake craniotomy patient, and she's doing great. She actually went to PA school and just graduated a couple of weeks ago. So for that patient we talked about before, again, I think everything we just said, he was confirmed oligodendroglioma. We did take him back to tumor board after surgery, and we had actually decided to surveil him with MRI given the clean appearance of his postoperative scan. I think some people may proceed with adjuvant treatment. That's something maybe we could talk about, what you guys might do with that. So as we continue to build the program, we started to, we first wanted to start with some of these more straightforward cases, and then kind of start to build into doing the more complex skull-based cases, because they require obviously more intensive postoperative management. So we worked with a doctor that we had been working with at UC, Dr. Lee Zimmer, and started to develop an endoscopic program. So this is one of our first patients. She was a 41-year-old presenting with physical stigmata of acromegaly. An MRI demonstrated a large invasive mass in the sella, extending into both sides of the cavernous sinuses, and a grossly elevated IGF-1. So we recommended her going for an endoscopic endonasal approach for maximal safe resection. We knew we weren't going to be able to remove all of it, given the circumference around the carotid there, and her tumor actually ended up being relatively fibrous, so it didn't just kind of suction out within the cavernous sinus. So this is her preoperative MRI. You can see the pituitary glands pushed down. This was her initial postoperative MRI. As we expected, we've got kind of residual tumor surrounding the carotids and within the cavernous sinus around the nerves, but she was neurologically intact, so we were happy with that. And then we worked with our radiation colleagues to devise a plan for radiotherapy. She ended up going conventional radiotherapy, and that's her pre-op scan there on the left and her post-op scan there on the right. And she was almost to a biochemical cure. Her IGF-1 levels were basically high normal at the completion of her therapy, and she's done well since then. And this is Dr. Zimmer. He was actually a full professor down at University of Cincinnati. We worked with him for years as we worked with the residents down at Cincinnati. And when we transitioned into the Mercy system, after we had been developing the program for a couple of years, I talked with him quite a bit and convinced him to come over and join us at Mercy Bon Secours as the director of ENT. So he's grown that department from himself only to over 11 physicians and multiple subspecialties within ENT. He's he's been a great partner in building the program, and was actually the NASPS president last year. So that's been a fantastic relationship. And we've worked with him to collaborate with our endocrinology group and all the healthcare systems that we work with here in Cincinnati to build our pituitary and anterior skull-based program. So then, moving on to the even more complicated things, we didn't do the lateral skull-based surgery at US for a couple of years. We continued to do that at university for a while. But then as we transitioned these patients, we continued to develop the program in order to take good care of them. So this was a 65-year-old that presented with a constellation of symptoms related to this large petroclival meningioma. She also, interestingly, had a lesion on the other side there that you can see, but was asymptomatic from that at the time of presentation. So this was actually growing, and she was symptomatic and was having a difficult time walking. So we devised a combined petrosal craniotomy approach for this patient. This was actually with the help of Dr. Breen, who I'll talk about a little bit later, but we were able to get, I think, a near total resection there. I think there was some tumor extending into the back of the cavernous sinus that was wrapped around the nerves, but a pretty good result. She did very well. So as we think about these patients, we've had quite a kind of a history of this activity here in Cincinnati. It was one of the first programs that really kind of focused on these skull-based approaches with Dr. Van Leveren and Dr. Tu, as well as Dr. Penzak in ENT. And they developed sort of this idea of having these combined labs with neurosurgery and ENT, and went around the country and taught everybody how to do these very difficult and very technically challenging operations. So for the combined petrosal approach, it's combining the anterior posterior petrosectomy with either a retrolab or pre-sigmoid approach to access the petroclival junction for these complex tumors that kind of extend both above the tentorium and below the tentorium. So kind of how I think about it anyways, there was a good paper that one of my colleagues published a number of years ago, Dr. Aziz, looking at the zones of the clivus and how they relate to these tumors in the clival depression. And we kind of use those to think about how we're going to approach the tumor. So for zone 1, we think more just anterior petrosectomy for tumors that are mostly supratentorial or right at the tentorial junction. It gives good access to these tumors and avoids the posterior fossa. You can also combine that with something like a Dolink approach, where you open the sylvian fissure and lateralize the temporal lobe so you can access the lateral cavernous sinus and tumors that are kind of coming more anteriorly or along the optic nerves. Zone 2 would be adding the posterior petrosectomy, which gives you the view down into the posterior fossa, especially when you ligate the sinus, not the sigmoid sinus, but sorry. And then that allows you into the posterior fossa with cutting the tent. And then zone 3 is really transcondylar approaches, looking at the lower cranial nerves and tumors around the foramen magnum and craniocervical junction. So this is a nice graphic that one of our illustrators put together, which kind of shows the 3 different approaches: the transcochlear, translab, retrolab, and then suboccipital, and how those differ in the access that you are able to attain. It's kind of a way that we do these surgeries. The drilling of the mastoid, which Joe helped us out with. And eventually, when you ligate that superior petrosal sinus, you can get a nice view by incising the dura along the inferior margin of the temporal lobe, cutting the tent, and then you get that nice view of the anatomy all the way there from supratentorial to infratentorial all the way down to the lower cranial nerves. As we continue to develop the lateral skull-based program, I enjoy surgery for acoustic neuroma or vestibular schwannoma, and again, that was something that we developed alongside Joe as we worked together for the first 5 to 6 years of his career, my career as well. So this was a 37-year-old that presented with worsening headaches, young guy, very active, really didn't have a whole lot of other symptoms. He had a little bit of imbalance, but his hearing was actually pretty good, even given the large size of the tumor. And then you can see his MRI here, the large homogeneously enhancing mass in the left CP angle, consistent with the vestibular schwannoma. He had some edema in his brainstem there. So this was his post-op scan. There's Matt. He gave us some permission to use his photos. So, we were able to get a great outcome using a retrosigmoid craniotomy and transmeatal approach with Joe. Unable to save his hearing with such a large tumor, but his face came back to normal. So yeah, as I said, kind of Joe and I met during our fellowship at MD Anderson down in Houston. We were able to recruit him as our ENT surgeon at UC, and we worked together for really the first 5 or 6 years of our practice together, developing our lateral skull base and acoustic practice. Our philosophy for these acoustic neuromas was kind of maximal safe resection with preservation of cranial nerve function. We developed the use of facial MEP monitoring for vestibular schwannomas, which I think has been helpful in preserving the nerve and really getting great outcomes. Our initial series included 28 patients with a gross total resection rate of approximately 91% and House-Brackman grade 1 or 2 result in about 95% of our patients. Most of the lower grades were in pretty large tumors. And we utilized, I think, most the retrosigmoid approach. Close second was the translab, and then a far distant third was the middle fossa. I've had in my practice, I don't know what you guys do there, but I've had a kind of a hard time for the indication for middle fossa. It seems like it's a narrow window of a very young patient with a small tumor and excellent hearing, where those can be useful. So we've only done a few of those, but we can do them when needed. So the last thing I was going to kind of focus on was, as we develop the center, kind of getting a lot of the clinical things behind us, we wanted to start to focus on research and education. So we really started to think about how can we bring or attract clinical trials to Jewish, and I had some industry relationships that we could utilize to do that. So this is kind of a case example of what the types of patients that drove us to do that. This is a 38-year-old that presented with headaches. She had a history of breast cancer, young woman, had a large solitary ring enhancing lesion in the right temporal lobe, suspicious for a metastatic deposit from her breast cancer. And this was right as we were opening the ROSE trial for comparing stereotactic radiosurgery after resection of metastasis to the implantation of gamma tau radiation in surgery. So this is her presentation scan there. She had a lot of mass effect, large tumor, right temporal lobe. So she was enrolled in the trial and taken for resection, and then placement of the gamma tau seeds following the initial resection. She did very well. I think the advantages of this approach, I think, especially in patients that have systemic cancer, they don't have to worry about, the additional treatment to their brain in the setting of already having to worry about, dealing with their systemic cancer. So it's nice that they come in, they get the treatment, the seeds are implanted, the radiation is delivered, and, they can move on to focusing on, on fighting their systemic cancer. That's been, I think, a big benefit. And so far, the results, at least anecdotally, have been good. I haven't had any instances of radius necrosis. Tumor control rates are high, I think is at least as high as this SRS. So I think so far our experience has been good. So again, the ROSE trial it was directed by MD Anderson. It's an ongoing trial that we're currently involved in. I think we've treated actually close to 25 patients to date. With this, I think 15 or 16 of them enrolled in the trial. So we're developing a pretty good experience with that. The type of radiation we mostly use at Jewish for our patients for stereotactic radiosurgery anyways is gamma knife. So we have a gamma knife there at Jewish. Dr. Warnick has been a huge mentor of mine over the years. I did my residency with him here in Cincinnati, and he's continued on with us at Jewish as the director of our gamma knife center, and really has been a huge boon for my practice and someone that I go to for advice. So I have to give him credit for a lot of the things we're talking about today. That's just our gamma knife center there at Jewish. So looking at kind of the preliminary data from some of the trial work that we've been doing, I think this is for meningiomas, this is for brain metastasis, and we've also been doing it for recurrent GBM, like I talked about, people that have failed clinical trials. All that preliminary data has been looking fairly positive. I think control rates are good, tumor control rates are good, and the complication rates have been fairly low. We also enrolled in a clinical trial, just kind of creating a registry for gamma tau as well. This is the trial we just spoke about. So the target is 180 patients over, I think we have roughly 15 sites open right now for the trial, with a 24-month follow-up for patients that have up to 3 metastatic deposits in the brain, one at least of which is surgical. And then the other trials we're working on developing currently are with GammaTile, again, the Pathways trial, which is doing what we're already doing, which is using GammaTile in the recurrent setting for GBM. And then we're also pretty excited about the other trial. We have a pretty good relationship with OHC, who's a large cancer group here in town. They have a very busy and active bone marrow transplant unit at Jewish Hospital. And we're working on, in the final stages of hopefully working on opening a CAR T trial for our GBM patients. So that's pretty exciting, kind of a homegrown trial. So kind of the next steps, looking forward over the next few years, what we're trying to accomplish, I think we're really just working on trying to create a, neuro-oncology destination at Jewish for the Southwest Ohio region, and also potentially hopefully the Midwest eventually, kind of utilizing Mercy Bon Secours' wide network of hospitals. Mayfield, we have the shoulders of giants to stand on. They've been in existence for over 85 years, and we've got a lot of collective experience at Mayfield doing these kinds of surgeries. And so that's been obviously something that I've leaned on heavily as I developed the center, and very grateful for. Looking at our volume at Jewish, this is just neurosurgical consults and transfers. 2014-15 is when we started, almost quadrupled those numbers. The 2023 numbers are 6-month numbers, so that's year to date. And this continued to rise. Our brain tumor volume took a little hit in COVID years, 2020, 21, 22, but this year, I think we're back on track. We probably should be hopefully up over 200 tumors this year. Looks that way anyways. And then this is just kind of the total neurosurgical case volume. So, not just focusing on brain tumors, but also focusing on the spectrum of neuroscience. We've kind of grown the neurosurgical volume at Jewish from roughly about 200 cases a year to, I think this year should be over 1,000. And we do the full spectrum of neuroscience surgery at that hospital. So spine surgery, functional surgery, neuroendovascular surgery. Those are all been part of the development of the hospital. We should be hopefully establishing a comprehensive stroke center in the next year or so. So for any trainees in the audience kind of coming out of fellowship and thinking about developing a practice, I think the biggest piece of advice I would give is, the most important thing I think is the people that you work with. They are the team that are going to support you. They're going to grow the center. They're the people that are going to take care of your patients. And I think that's been my biggest blessing doing this, is working with the people that I've gotten the chance to work with and learning from them as we did it. Certainly, Dr. Zimmer and Joe have been two key elements. Dr. Warnick, Dr. Gazal, who's my junior partner in skull-based surgery and kind of works hand in hand with me with all these very complex cases. So it's been a really great experience. Dr. Kachoris down here at the bottom, John, has developed our neuro ICU program and recently hired 2 more physicians. So that's been successful and growing. So I think that's been my biggest word of advice, is surround yourself with good people. So this is my family. This is Justine here, my wife, and my 2 kids, Dino and Frankie. When I'm not working, I do enjoy, I'm a race car enthusiast. So I got my son here out at the track, learning how to drive his go-kart. That's him in the orange helmet there. So find some fun things to do here in Cincinnati. And I guess we can open that up for questions, Kai.
Yeah, definitely a great talk, Vince. I'll start, and then other people can join in. But so it's been a while since I was looking for jobs, but when I was coming out of residency, one of the positions that was open is a place that had only 2 craniotomies, just like you mentioned. So my biggest fear in starting one of those jobs or going to one of those jobs was the complications. If a complication happened, what do you do? So can you comment on that when you first started with the low volumes? Like if you tried a complex case or even any case, if a complication happened, how you thought about that mentally?
Yeah. So, I mean, the one big benefit we had is that we do cover, we cover all of the hospitals here in Cincinnati, and I had a lot of partners with a lot of experience. So that was reassuring if the patient were to need to be transferred. We have places where that can occur. But honestly, I really took a slow approach to it. We were very thoughtful with the kind of cases that we did there when we first started. We started with simple craniotomy cases like, chronic subdurals and, whatever came in through call, metastasis and maybe small meningiomas on the convexity, and just got people used to taking care of these crani patients. As we said, I did a lot of work with the ICU and the nursing staff and the OR staff with those neuro 101 meetings, trying to get the staff trained and knowing what to look for with neurological changes and how to update people and how to contact people. And we really established all that kind of protocol and baseline work before we even started bringing patients over, because we were at the university for a year and a half, 2 years almost, before we really had to fully switch over. So we did a lot of groundwork before we started doing the complex stuff. I really didn't start doing the complex skull-based stuff there until the last 2 to 3 years. So I really kind of reserved that stuff for once we had the hospital up and running and we had the the infrastructure in place to take care of those patients. And we've had a good experience. I mean, I think I've been delightfully surprised actually of how when you invest in people, you make them feel part of the team, you educate them and give them opportunities for learning. We got all our nursing staff ENLS certified. So we have almost 50 nurses in the hospital that are certified with the ENLS system. So, I think when you build into them and give them a chance to rise, I think they've really surprised me. We've had a really excellent experience. And I think right now it's probably the best hospital in the city for neuroscience.
Great.
Wendy, did you have any questions? Yeah, perfect.
Yeah, I have a question. I mean, first of all, thank you for sharing that experience. I think, I guess the question I have would be about, clearly you had a significant growth in terms of your tumor volumes, and, definitely a testament to your excellent outcomes and I'm sure your bedside manner too, and patient care. But I was just wondering what kind of efforts you led to help to build that referral base, whether it be through strengthening, those referring partnerships or marketing. Did you have specific campaigns that were really successful to help build those volumes for you?
Yeah, it's a good question. Marketing is oftentimes a struggle with, especially with these large healthcare systems. But I mean, we built it initially through Mayfield, and we had a lot of volume in brain tumor at Mayfield, separate from Mercy to start with. But I think the efforts that we've focused on mostly have been, just developing those relationships with the community. So we have a really strong physician liaison program at Mayfield. So I went to, we spent a lot of time talking with ENT groups, talking with ophthalmology groups, endocrinology groups, primary care doctors. We actually have a couple seminars every year where we invite people in from the Mercy network, the primary care doctors, to just sort of educate them about what we're doing, the types of cases we take care of, and kind of reassure them that they can send these complex patients here and know that they're getting excellent care. We did some marketing type things, with typical TVs and billboards and Facebook and stuff like that. And I think it had a modest impact, but I think what you said is the most important thing. I think if you take good care of the patients, give them great outcomes, I think that builds as much as anything else. They talk to their family, their friends, their physicians, and, when they have those kind of experiences, then it kind of grows organically as well.
Yeah, no, absolutely. Yeah, we found something similar. So thank you. I don't know if anyone else has other questions. I guess I'll ask one more. So just from the research perspective and the clinical trials, what was the greatest challenge you ran into in terms of trying to build your clinical trial portfolio where you're at?
I think it was multifactorial. One issue was when we split from university, a lot of that infrastructure kind of went to university. So it did take me a year or two to work with Mayfield to secure funding to hire clinical trial coordinators and nurse navigators and those things. So that was one part of it on the Mayfield side. Then we had to establish our IRB. And then we working with the hospitals. I think one of the bigger challenges is when you're working with multiple healthcare systems, kind of getting through all the hoops and hurdles of establishing that legal arrangement to run the trials within each of these healthcare systems. That was probably the biggest hurdle. And then getting the buy-in of all the physicians to run the trials. But I think now that we have it all established, it's actually an advantage. I think at Mayfield, that is one of our advantages. We can be a little more nimble than some of the bigger healthcare systems. When we want to adopt a trial, it's as simple as, having a board vote and say, yes, we want to do this trial. And then within a couple of weeks, hopefully we can get it up and running. And so that's been an advantage.
That's impressive. Couple of weeks.
Yeah, we had one open recently from the time we got asked to the time we had it open was almost the 3 to 4 weeks, because we already had all the kind of agreements in place. So.
Are there any other questions in the group?
Oh, yeah. Well, thanks guys for the invitation. Again, it's been a pleasure meeting everybody and spending time with you guys. I think you guys have a lot to be proud of, and program seems like you're really growing in a positive way. So it's been a pleasure to meet with you guys.
Thanks, Vince. Always a pleasure.
Are you guys? Is this done, or is there more for this meeting?
Oh, sorry. No. That should be it. Yeah.
Okay.
Eric.
That sounds good. You guys have a good day.
Thanks, Vince.
Have a good weekend.
You too.
Thanks. Thank you, Dr. DiNapoli.
Thank you.